about a third of them spend at least 2 hours a night on average in glucose below 60. So even wearing the CGM. So either they didn't wake up or they didn't react, but the CGM recorded a hypoglycemia for more than 2 hours in 23% of these patients. And median hypoglycemic nights per patient was about 7%. So the patient that had better A1Cs actually had higher rate of hypoglycemia, nocturnal hypoglycemia, which is basically when you want to tighten the control. That's what is expected, that probably we are running them too tight. So I think all in all, in summary, take-home message is that these devices are helpful. They are hopeful for the future, but there are several steps that needs to be taken and they need to be improved. Do we think that they are helpful for the patients? A lot of patients get benefit, as you see that it has been proven that it can be beneficial, but also we need to kind of adjust our expectations going for the therapy, because if we expect that it's going to do really the bulk of the work for us and we are not going to have to do anything, that is going to end up being discouraging. So it does not eliminate, CGM does not eliminate the finger sticks, and they have very good features, but still the patient or the parent is the one that needs to act on them. All the outcomes are directly related to the frequency of use of CGM. So this is the picture on the left is the very first insulin pumps. We have come from there to the other one, that is the recent insulin pump, and the control to get to the point that we have an artificial pancreas. We just need to close the loop, meaning that to have those algorithms to connect the readings and the delivery of insulin. And actually that has been studied as well. So 2009, a few patients in patient settings, a group in California, they showed that they could prevent nocturnal hypoglycemia using pump suspension and predictive algorithms. In UK, there has been several studies that, again, this one was all pediatrics, seven patients, and they use a model predictive control approach, and insulin delivery was shut down when the glucose reached to the point that the algorithm would predict that it's going to go into the hypoglycemic event. And actually they had very good results because the glucose stayed very stable after the shutdown. One of the flaws of their study was that they didn't check for the ketones after the insulin delivery was stopped. So that's always a concern. One of the reasons that the VAO is not available yet in the US is the concerns that FDA has in terms of if you are stopping the delivery of insulin for a couple of hours, are you increasing the risk of hyperglycemic events or producing ketones and DKA? And I think the studies that are right now are being done here are all trying to address that point. Again, another study from UK, and they had 19 patients on standard pump. They kind of randomized to a standard pump or closed loop, and actually the way that they did the study, these were inpatients, so the nurses would, when the algorithm would predict that the glucose will go down, the nurses would manually stop the pump, so it wasn't a completely closed loop. But in the group that had actually were manually using the in actually their study group. There was no significant hypoglycemic events, but the group that were on standard pump therapy, they had 9 significant hypoglycemic events, which is quite significant. So they are working on it, and what future will hold would be that the systems will be developed in a way that we can use it actually not only in the inpatient but also as outpatient. JDRF just recently, if you look at their website as of a few days ago, they posted that they are encouraged by the draft of FDA artificial pancreas guidelines. This is something that JDRF has been working on for a while to produce those for FDA to produce those guidelines that actually gives the industry some incentives, like what exactly they are looking for. So hopefully some of those devices that are not available yet will soon be go through clinical trials and be available. 2 other things that also would be helpful, hopeful for the future of treatment of diabetes are the immunomodulation. So basically, as we know, the type 1 diabetes is an autoimmune condition. So so far all we have talked about is the insulin treatment and insulin delivery. We haven't addressed the actual pathophysiology of type 1 diabetes. Now there has been studies looking at TNF alpha binding agent called Tanacept, and so in one study, this was published in 2009, they randomized 18 patients who were between age 7 and 18 and were just diagnosed with diabetes with less than 6 weeks. They randomized the control group and treatment group with subcutaneous injections of Tanacept or placebo. The result was that after 24 weeks of the study, the control group had lower A1C, they had increase of 39% in their C-peptide area under the care, and which actually the C-peptide in the other group had dropped by 20%. So basically this was like a prolonged honeymoon or prolonged remission. And also the study group had required lower insulin dose. So this was quite promising. Another study on a form of INF alpha also showed similar results. This was 128 patients aged 3 to 25, and after 1 year there was no difference in their A1Cs, but the C-peptide area under the care showed that the patients on the study group actually had beneficial effects, and they kind of preserved their C-peptide function. I'm sorry, beta cell function. So basically, there is some promising studies in that regard as well. But for now, what is available and in the market are the insulin pumps, 2 forms of insulin patches that we talked about, and the 2 forms of CGM that we have. But at the end of the day, it's the patient or the parent that is the main decision maker in the management. So any questions? Question. No, they work by infrared. So what all that is attached to the body is that sensor, which is the size of a quarter. But there is no connection, no wire connection from the sensor to the screen actually. This is what goes in on the body. So that part, that is attached, but the screen is remote.
On the outside.
Yeah, not on the inside. Yeah, because you got to change it. this is the navigator, but it's not available anymore. What is attached is that patch, which is basically the sensor and the transmitter. And this one is, oops, this one is the Medtronic one. So this is all that stays on the body. And then they either see the numbers on the pump, or they have like a screen, like which is called Guardian. Or the other option is the professional CGM, which we can use it in the clinic. We just give you this part, and then we download it later. But you can't see the numbers; it's kind of blind. It has to be close, like 20 feet, to be able to capture the signal. Yeah. Although the navigator, as I said, one of my patients, like they can catch it from the soccer field. So sometimes it might work a little longer distance. Good question. It has an adhesive at the bottom, so most of them are quite. It depends on the type of the skin. So some people that like sweat a lot, or if it's a hairy surface, it might be a little harder to keep it on the skin. So what happens? We give them like an extra adhesive to put on the top. But generally speaking, it stays. So the pump is a delivery system. Yeah. For reading of kind of giving you an idea of where you're going. The one that I see what you're questioning. The one that delivers insulin is this one. Is the patch, the Omnipod.